Okay, good afternoon, everyone. I think it's afternoon here in Ohio. It's late morning, I think, for California, and other places are in different time zones. But thank you so much for joining us. Greetings. This is the Always Use Teach Back Now More Than Ever workshop, and I'll do a little bit more of an introduction in just a moment. I want to have you do a couple things before we get started to hopefully help it run more smoothly. So you see in the chat, if you don't have the chat open, make sure you open it. There are two tools there, two PDFs. There's a couple duplicates, but there's a AUTB Toolkit Tools, or Always Use Teach Back Toolkit Tools document, and Making TB Teach Back an Always event. Could you please make sure you download those and make them accessible so that you can access them a little bit later in our session? We were doing a little practicing so that you might see those in there more than once. And there's a code there that we'll be using a little bit later, but we'll copy that again when you need it. And then once you've finished that, since we don't have the luxury of being in person and we don't have the luxury of more time than I would love to have, go ahead and just chat in something, who you are, where you're from, what your role, your organization is, and whether you're familiar with the Always Use Teach Back Toolkit. And I'm going to give you just a minute to do that, and then we'll get started. So George, I'm not seeing the chat. Do I need to reopen it?
Yes.
Oh, there we go. I see it. People were just they were downloading those documents, and I appreciate it. Thank you. I should be good. I see Christine and Jen, Julie, Devaki, Judy, Texas, New Jersey, Aetna Better Health, Working in Wellness, Sacramento, Infectious Disease Health Educator, Danny in Kentucky, some people that are quite familiar with the tool and some that are new to it. Got Philadelphia. We've got a really nice range of people and roles from around and organization types too from around the country. I don't know if I've seen anybody from international yet. We usually often have someone or a couple people from there. So keep answering that, and we'll go ahead and get started. Thank you. So my name is Ann Abrams. I am an assistant professor in pediatrics at Nationwide Children's Hospital and the Ohio State University College of Medicine. My main focus of work is in graduate and undergraduate medical education. I focus a lot on health literacy, health disparities, and health equity, quality, and safety. In Iowa, where I lived before we moved back to Ohio, I did a lot of work in health literacy, leading a system-wide health literacy learning collaborative with Iowa's largest healthcare system. And we focused on that as a quality and safety initiative. And in fact, that was early organizational health literacy work. And one of the tools we developed as part of that some of you may be familiar with or may find helpful is a guidebook for becoming a health literate healthcare organization. So with that, I'm going to go ahead and move forward. I want this to be as interactive as possible, even though we're on a bit of a tight time frame. My goal is really to equip you to lead the work of making Teach Back an Always event. This isn't a basic health literacy training because most of you are probably familiar with it, but you'll see some of what you might consider basic health literacy content because I want you to think about how to strategically deploy those materials and resources to advance use of Teach Back. So I want to start with a quick poll, seeing where you feel you fall on a scale of 1 to 5 about how confident you are that you can advance use of Teach Back in your organization. So George, if you could activate that poll, I'd appreciate it. and 1 is not very confident at all, and 5 is quite confident. Can we give them a little bit more time since only half the people have voted? There we go. We'll see if we can get everybody to vote before we close it. I know a few people are on their phone and maybe they can't do the poll. So it looks like people on the whole feel pretty good about their confidence. And we'll see if we can nudge that along as we talk this afternoon. So we can close that poll. Can I do that or do you do it? Or can everyone see it or just, there we go. Okay. Another important part of working, I think, in almost any area in healthcare to improve quality or safety or whatever, is to work with patients and families. And in Iowa, especially, we were very fortunate to be able to work with the new readers of Iowa, or the who are adult learners who were learning how to read as adults. And we had some wonderful partnerships with them where they helped us with training and education and shared their stories and participated on our committees and helped with materials development. And we're fortunate to be able to have a story that Norma Knoyer, a lovely woman who was one of the new readers of Iowa, shared with us about a personal experience that she experienced. So I'm going to play that video for you now, the voice of the patient, and ask you to kind of really listen closely to what she shares.
Well, he had brain concussion. The doctor says, you got a bruised brain. That's how he explained it to him, because that was a big word. I don't even know what it was. And it helped me too. He was going in and out of convulsions. I called the doctor. I did not understand. I was giving him, I think, 3 teaspoons 3 times a day. And he told me to give him 1 more teaspoon. Well, I thought he was 3 times a day, 1 more teaspoon. So I was giving him a tablespoon 3 times a day. The poor little thing was walking in the doors and the walls, and here was a chair, and he'd sit down over here. And I couldn't figure out what was wrong with him. So I called the doctor, and he says, bring him in. Well, he wasn't having no more convulsions. So I took him in, and he asked me, and I told him, and he says, no, just 1 more extra teaspoon. Oh, it was just a lack of communication, because I did not understand. And if I should have asked questions, but I didn't. Now I would have. But so wonder I didn't harm him worse than I did. But he's fine now.
Okay, so I'm going to ask you to join a breakout room. We've got those set up. We'll give you about 8 or 9 minutes. And because it's going to be hard for people to report out verbally, we'll ask you to kind of enter your thoughts in the chat with what you discuss. And 2 areas that we'd like you to focus on. First, hearing what Norma had to say, think about what your observations are about her perspective on what happened. What about the approach that the physician took in that encounter? And whether you see any similarities to situations in your own setting and how this might have been prevented, because clearly this was an unfortunate event that really bothered and worried her and could have had really serious consequences. In addition, spend a couple minutes talking about what you want to accomplish through this session today regarding using TeachBack for yourself and your organization. And then when you come back, we'll have you chat that in. So George, can you open those breakout rooms? Okay. I hope that you had some really good discussion, about sharing ideas or finding other ideas about what you want to achieve through this workshop. and also some insights about the video that you saw. I see that Jen has already typed in something from her group. Please do enter those in the chat since we don't have time for a more formal report out. But her observation that it felt like the patient was blaming herself and the physician used shaming language. I really think that that is a great observation. She used that phrase, "It's a wonder I didn't hurt him worse than I did." She really took that on herself, and it was very personal to her. And any other group want to weigh in a little bit? Most want to hear pearls or training insights for this skill, which we will get to. The onus should have been on the physician to explain it. I mean, he talked a lot. She was very confused, right, about teaspoons and tablespoons and one extra dose with each time she gives the medication. A lot of opportunities for confusion for anyone, especially someone that wasn't familiar with that and even maybe what or why they were doing that. So hopefully at the end of the day, we recognize that this is a situation where TeachBack could play a role, and we do so much telephone medicine, even more now, so that it's really important. And hopefully you've got some ideas about what you want to accomplish as well. For public health, it prompted us to think about how not just patients, but colleagues may need some of this clarification too. Yeah, our colleagues who work in communications and marketing, quite a bit. Sometimes those things seem to sort of work not at odds, but to not be on the same page, if you will. So this leads to the objectives for today. I really want you to be able to describe how organizational health literacy, including TeachBack, is fundamental to safe, high quality, equitable care. I want you to be familiar with and be able to talk about and use key components of the Always Use TeachBack Toolkit, and think about those that would be useful for you in your setting. And then to come away with some next steps, some concrete next steps that you can use to increase use of TeachBack by either individuals you work with or organizationally in your setting, especially now in the time of COVID. We've heard so much information about how critical clear communication is during this pandemic. So now this is the part where I want to focus on sort of making the case, describing how organizational health literacy is fundamental to these key elements of care. And you're going to hear some material you've already heard, but hopefully this will help you to use it strategically. So we know that this traditional definition of health literacy is an individual-based one, the degree to which an individual has the capacity to obtain, process, understand health information and services to make health decisions. I know that you're familiar with the adult health literacy data from the National Assessment of Adult Literacy that showed about a third of US adults have below basic or basic health literacy. Approximately 50% have intermediate, the purple in this pie chart, and about 12% have proficient health literacy. Proficient not meaning that someone has a graduate degree in health or healthcare, but really just someone who can work their way through a table with insurance benefits or maybe an immunization chart. And the takeaway here, which hopefully you can use very effectively, is that the bottom line is that really 90% of US adults lack the skills needed to navigate the health system in the US. Not purposefully, but the way our system has evolved, it really leaves almost 90% of people in a position where they struggle. We also know that some people are at increased risk for low health literacy. That doesn't mean that every one of these groups, people in these groups, has low health literacy, but we need to recognize that the risk is increased for certain groups. So when you look at the data by age, we see the number who have the risk of those with proficient health literacy is, the percent of those with proficient health literacy is lower, and up to almost 70%, depending on the exact age, can be in that limited health literacy group. We can look at the same data by race and ethnicity. Again, not assigning this to the group overall, but we see that the risk for limited health literacy of 50 to 60% is higher among people who are of Black or Hispanic race and ethnicity. Again, that's the risk. It's not a specific statement. And finally, those when we look at health literacy by type of health insurance, we see that those who have Medicare, Medicaid, or no insurance, again, have a lower percentage of those with proficient health literacy, and 2/3, 50%, 2/3 are at risk for limited health literacy. So keep that in mind as you think about what you're working on strategically at your organization. And recognize that many of the people in these groups likely have multiple chronic health conditions, and they may have difficulty accessing and using the health system. And also recognize that the contributors to those risks are very complex. They're grounded in a lot of things like access to quality education, access to healthcare, community resources, systemic racism, poverty, and other social determinants of health. So again, those present opportunities to align work in health literacy with addressing those concerns. Again, those demographic groups, as we've heard a lot in the last couple of days, are at risk for increased risk for COVID infection, hospitalization, and death. So that just, COVID has highlighted those disparities. We have decades of data that show the association between low health literacy and poor health outcomes. They're related to health, less healthy behaviors, less use of preventive services like vaccination, less personal health knowledge about caring for chronic conditions, less understanding of true informed consent, poor ability to interpret medication labels and health messaging, increased utilization in the emergency department, excess hospitalization, and among some groups, increased mortality and poorer health outcomes, along with estimates of higher healthcare costs, both directly and indirectly, over $200 billion. So the pedigree, if you will, of health literacy's relationship to quality and safety, you can trace that back to the 2004 Institute of Medicine Committee on Health Literacy report, where one of their key findings was that health literacy is fundamental to quality care and explicitly relates to at least 3 of the 6 aims of quality improvement described in the IOM quality chasm work. Those are patient safety, patient-centered care, and equitable treatment. And at the same time, the quality chasm work group identified priority areas for national action to transform healthcare quality in the US. And 2 areas, self-management and health literacy, were identified as cross-cutting priorities to improve healthcare quality throughout our country. All the other areas were specific conditions, say heart failure or obesity, but they recognize that health literacy is cross-cutting. It applies to all ages, acute, chronic, preventive types of care, all settings, all stages of life, prenatal, end of life, palliative care, et cetera. So it was recognized early on that health literacy is fundamental to quality and safety. You can also align it with the Institute for Healthcare Improvement triple aim, which is another framework for thinking about quality. And that talks about simultaneously working on 3 dimensions of healthcare: improving the patient when you're in the healthcare system, experience of care, which talks about quality and satisfaction; improving the health of populations, meaning those who may not come into our settings, but who, if they stay well, are less likely to need healthcare in the healthcare setting; and reducing costs. So again, health literacy aligns nicely with that triple aim. The Agency for Healthcare Research and Quality states that patient safety refers to freedom from accidental or preventable injuries caused by medical care, so that practices or interventions that improve patient safety are those that reduce the occurrence of these preventable adverse events. And health literacy can contribute to doing just that. Our friends at the Joint Commission state that the safety of patients cannot be assured without mitigating the negative effects of low health literacy and ineffective communication on patient care. So again, recognizing how fundamental health literacy is to patient safety. And the National Quality Forum endorsed teach-back and reader-friendly documents during the informed consent process to reduce harm to patients. All of this helped evolve the definition of health literacy and increase recognition that health literacy is the product of the individual's capacities that are talked about through that original definition, and the demands, the health literacy demands that the system puts upon those people and the complexities of the system. So that when we address health literacy, it means including improving the skills of the system, us, as we communicate with individual people, whether they're patients, family members, employees and staff, or those in the community. The IOM Roundtable on Health Literacy members defined those 10 attributes of health literate healthcare organizations almost a decade ago. And I imagine many of you are familiar with them, but they're so important that I think they help provide a really well-rounded approach to a comprehensive approach to addressing health literacy in the organizational setting. And it involves leadership, planning, evaluations, the safety and quality, the care environment, access and navigation, communicating costs, including consumers upfront, not just after the fact when we develop something new, not saying, don't you just love what we developed, but having their voice at the table. Preparing the workforce, using health literacy in our interpersonal communication to ensure and check for patient understanding, focusing especially on high-risk points, and then also materials that are easy to read, understand, and act on. And what we're focusing on today is primarily how we can work to prepare the workforce to do this interpersonal communication and teach back well. The other exciting piece is that Healthy People 2030, which guides so much of the work of our nation over the next decade, specifically elevated health literacy and pulled it into their overarching goals and foundational principles, talking about how eliminating health disparities, achieving health equity, and it cannot be achieved without attaining health literacy in order to improve the health and well-being of all. So it's explicitly included right up front as not just a nice thing to do, but a necessary thing to do. And they tweaked a little bit the definition of personal health literacy by focusing on use and actionability, and then added this new definition of organizational health literacy, which is really important to us as we, again, advocate to increase use of health literacy informed strategies in our work and by our colleagues and organizations, and tie it very closely with health equity. So organizational health literacy is the degree to which organizations equitably enable individuals to find, understand, and use information services to inform their health-related decisions and actions for themselves and others, whether it's their family members or friends. And together, these two definitions now constitute health literacy. So this is a big deal, and it can impact research and implementation and organization, education and training, and hopefully care and quality. And I appreciate the comment in the chat about loving these new definitions. Great. So now I'm going to force you to be a little bit pickier. George, we're going to pull up the next poll. I want you to pick just one area where you see the greatest opportunity to address health literacy and promote use of teach-back in your organization. Now, I'm always pulling more things in, but if I have to really pick one, I'm going to make you just pick one. I just want to see what bubbles up to the surface. So we've got about half the people have voted. It's kind of fun to see it changing. Education, equity and safety. Give it just a couple more seconds here. All right, why don't we go ahead and wrap that up? And it looks like the greatest opportunity that stands out is education. And I think that's probably a good observation in terms of the education we do impacts equity, quality, safety. And I was worried about if people wrote in other, we'd have to figure out how to find out what those other ideas were, but we're okay on that. All right, thank you. So now let's move into what we can do. Hopefully that gives you some added ideas about how you can use those various tools and the data in your toolbox to advocate and make change. So now let's look at some ways that we can offer solutions. If we were doing a training itself, I would show you this video that shows a physician counseling a patient, a teenage boy and his mom, about how to use an inhaler for his exercise-induced asthma. We don't have the time for that today, but I can tell you that what people always comment on, what they observe, is that although the physician is a very nice, caring, friendly physician, he still talks very quickly, gives lots of information, uses technical terms and jargon, medical jargon, has a lot of yes, no questions. And as he's gliding toward the door, he asks if there are any questions, which makes it really hard to stop him and ask a question if you really did have one. And at the end of the day, we know that Nolan and his mom didn't really understand what they needed to do. So what, right? The patient was in and out, the turnaround time was probably fine, and we're on to the next patient. But so what can follow? He could make a mistake. He may not even use it because he's confused and afraid it could hurt him if he did it wrong. We might label him as non-compliant or non-adherent because he's not doing what we told him. Ends up with poor self-management of his chronic condition, asthma. And that could end up having increased utilization in the urgent care, the emergency room, or even being hospitalized. That translates into missed school and work and poorer health outcomes. So what can we do? We can always make sure that we're using health literacy universal precautions, plain language in our written and verbal communication. And at the end of the day, make sure people understand by using teachback. So universal communication principles, clear communication helps everyone, not just certain people. You can't tell by looking at somebody whether or not they understand. So don't waste time and try to figure it out or think you can figure it out. And recognize and tell others that you work with that anybody can have trouble understanding health information depending on their circumstances. If they're sick, if they're worried, if they're in pain, if it's their child they've been up with all night, if they're preoccupied, all those things interfere with remembering, understanding information. So that calls on us to use clear communication words and tools for everyone. What does that mean? It means always using plain language, slowing down, shorter statements, focusing on the 2 or 3 most important things for each topic. And again, at the end of it, check for understanding with teachback. So what is teachback? I think it's really important to keep several key points in mind. So it's asking people to explain in their own words what they need to know or do in a friendly way. So it's not just repeat back or parroting back, it's in their own words where they're internalizing it. And it's very important that we convey that it is not a test or a quiz of the patient. It's a measure of how well we did when we explained it. A lot of providers I find, I continue to find, I'm surprised, they're very worried that the patient will feel put on the spot or the parent. And I think they might feel put on the spot if it's not asked in a good way, where we're saying, I want to make sure I did a good job explaining it. And it's a way to check for understanding, but don't forget, if needed, if they can't explain back in their own words, you need to re-explain it in a slightly different way and check again. So there's sort of three key points that sort of get lost sometimes in all the general talking that we do about health literacy and teach back. And that standard example is, I want to be sure I explained everything well. Can you tell me in your own words what you will do so I can be sure I was clear? So again, you're framing it in a pleasant way. You're saying, I want to make sure I did a good job, and you're asking for it in your own words. So here's some other examples. You don't want to just say that over and over. So the question about, what will you tell your daycare provider or your husband or your Sam's grandmother about how to give Sam his medicine? If you're setting goals in terms of behavior change, we've gone over a lot of information, lots of ways you can get more exercise. In your own words, can you go over what we talked about and how will you make it work for you at home? So you're incorporating some teach back, some goal setting, and some self-talk, if you will, to improve how they're going to get a little bit more exercise. And we did some changing up of our follow-up calls. When we used to say, do you have your follow-up doctor appointment scheduled? Yes, no. Now we ask, please tell me when your next appointment with your doctor is. So that way, if they don't have it scheduled, if they don't remember, we can help with that. So think about how you can use teach back in various ways. So I'm gonna take just a second and give you two quick demos of how to do that well.
So to make sure that I taught you how to use this, okay, I want you to tell me and demonstrate. Don't put your mouth on here though, okay, because my dirty mouth was on. Okay?
Okay.
Good. So see what a good job I did at teaching, or if I didn't do a good job, then we can have you do it over. So can you talk as you're doing it?
So that's one way. It's kind of a friendly relationship building example. And here's one more. I'm glad you like the spacer. Me too. Thanks, Jennifer.
So Nolan, now that I showed you how to do it, I'd like you to show me how you're going to do it before practice to make sure that I didn't forget anything when I taught you. So I'm going to give it to you just like the pharmacist is going to give it to you. And I want you to just show me how you would use it before practice.
All right. I think this is called the inhaler. Oh, no, it's this side that you put it on. And then I should just put my mouth on this side and just squirt 2 puffs right in a row and then just inhale it in. And then I should probably do it like right before practice. I mean, I think that's all I need to do.
Good. So let's go over that again. There's a couple of things I must not have explained very well.
So I showed you this, excuse me, second one. It's a little bit of a different way of asking for the teach back up front. And it also kind of shows you a way to move into that's close, but not quite right, without, again, making the patient feel judged or criticized or critiqued. So I think Dr. Cheney does a really nice job in these 2 videos showing how you can use teach back and just make it seem very comfortable and very natural. So he took responsibility for being clear. He had a very caring relational tone of voice, the body language. He sat down to be more one-on-one and had the patient explain it back. Don't forget that it's not just the job of the physician or the nurse or the educator. Teach back is everyone's job. Let's make sure the paperwork gets handled right. Can you tell me what you'll do with these forms? So all our good, hardworking colleagues in registration can use teach back. I want to be sure I did a good job showing you how to find the lab. Can you tell me how you will find it? And we want to be sure you understand what your insurance will and will not cover. Can you go over it for me using your own words? This will help me know if I explained it well. Again, working in that personal, taking responsibility, and then asking for them to explain in their own words. And yes, I think Mary Susan mentioned Helen Osborne's great book, reinforcing or congratulating them. Yes, you got that right. That's really good. And here's the part that I want you to, I want to explain more clearly to you, or something like that. But yeah, that reinforcing is a great observation, and thank you for sharing that. If people can't teach back, make sure they have their hearing aids, their glasses. If you're like me, you can't hear without your glasses on. See if they want to include a family member or a friend. Obviously, if there's a language issue, you want to access trained health interpreters. If there are literacy or cultural barriers, you may ask another member of the healthcare team to help. You may need to schedule another visit or a follow-up call. And if somebody is really struggling and they're entering into the health system for more than just a short visit, you may want to pass that along so that they get that extra help throughout their experience there. If there's more than one topic, you're probably familiar with the concept of chunk and check, teaching the 2 or 3 main points for the first topic and doing teach back then before you go on to the next topic, rather than going through everything and doing one giant teach back at the end. It's always good to support whatever conversation and teaching you do with reader-friendly plain language materials. Mark them up, circle things, put a star on them, even if they're not in plain language, especially if they're not in plain language, circle things so they can go back and find the important information later. Use it for all key patient education and communication and get used to where you'll fit that in. And it's nice to document the use of teach back and how well the patient responded to it. So there are quite a few studies on teach back. I want to just focus on 3 because of how they relate to the next, my next slide. We are familiar with Dean Schillinger's original, one of the early papers on use of teach back, where in a family medicine outpatient setting, use of teach back was associated by the physician was associated with better glycemic control for their patients with diabetes. Think published a paper where they added repeat back or teach back into their standardized computer-based consent work. And they found that the patients who used the teach back arm of this study significantly improved their patient comprehension. And Press did a study with hospitalized adults who either had asthma or COPD and found that use of teach back or teach to goal was associated with fewer acute care events within 30 days of discharge, and especially among those with lower health literacy. So those were 3 studies that showed its benefits. And what is the biggest concern that people express when they're worried about using teach back is the amount of time, right? They're really worried. So it's our job to help them, our colleagues, look at use of teach back as an investment and not an add-on. So in Schillinger's study, it was 1.8 minutes more per encounter, which doesn't sound like much, but if you add that up over 30 encounters, that's an extra hour a day. The Fink study with consent was 2.6 minutes more. And I would argue that if you're doing and having an informed consent process, that an extra 2 to 3 minutes is not a bad investment of time. The Press study with the adults using metered dose inhalers was the teaching and teach back were actually used by their respiratory therapist, which again, I think is a wonderful way of showing how this is multidisciplinary, interdisciplinary, how we work with each other, and a really great deployment of their expertise. So you can make that case for some of the time investment, but also ask people to think, well, what are they doing that may not be adding value? What are the interruptions for clarifications? What are the other things where maybe they can trade off? And also we know that practice improves how we do things, and it takes, a few weeks to build a pattern or a habit into our current workflow. So the more you do it, the better you get. And we also observed that when people start using teach back and after half dozen times realize that patients never understand or struggle to understand how you explain a certain concept, you start to explain it more clearly up front. You alter your description, you use a more plain language explanation so that then you don't get caught in this endless loop fear of teach back and having it continue and continue. So, and at the end of the day, why do we do what we do? Why do we come to work? We want to improve outcomes and care for patients. So one of our physicians in Iowa observed that without teach back, the only way to find out if a patient didn't understand could be a mistake that could result in harm. So at the end of the day, again, thinking about why are we doing this? And this is an opportunity to improve what we do and how we do it and improve patients' care and health. So I wanted to spend a few minutes talking about the Always Use Teach Back Toolkit. And why is it called that? Well, ARC defined a never event as adverse events that are unambiguous, serious, and usually preventable. Things that are so bad they should never happen in healthcare. Operating on the wrong part of the side of the body, pushing IV potassium, a patient death from a medical error. Those are never events. And then the Institute for Healthcare Improvement conceptualized the reverse, the concept of an always event. Aspects of the patient experience that are so important that healthcare providers should perform them consistently for every patient, every time. So these are always events. So the name of this toolkit was making use of TeachBack an always event to help all healthcare providers learn how to use TeachBack whenever it's indicated to support patients and families throughout the care continuum. And the focus was a little bit especially during transitions within or between care settings. So there's the URL for Always Use TeachBack, which has a description of how to use the toolkit, an interactive learning module, coaching tools, and some additional references. And IHA is kind enough to host the toolkit in their Health Literacy Solutions Center. If you're new to it and want to think about how to use it, there are sort of guideline steps for how you can use it personally. How do I use the toolkit to improve my own use of TeachBack? If you're in a role as leading a team or a supervisor, a manager, a unit director, if you're coaching others to always use TeachBack, there's a stepwise guidance for how to use the tools to improve the use of TeachBack. The interactive learning module, it does not take 45 minutes. It must have been one of the early iterations, but anywhere from maybe 15 to 25 minutes. And it really has kind of two parts. It describes TeachBack and demonstrates its effectiveness as an intervention to improve communication. And it contains interactive video and self-assessment questions that help to enhance, confirm, and reinforce one's ability to use TeachBack and build it into their practice. And it follows a patient through hospital discharge, home health, and follow up with their primary care physician, and then a scenario that ties that together. Yeah, the URL, I will have that on a slide at the end of the presentation. It's teachbacktraining.org, and it's also teachbacktraining.com. I don't know, George, if you could type that in, maybe you could type that in, teachbacktraining.org. And these are just screenshots showing hospital discharge, home health encounter, and her outpatient follow-up visit. There are tools in the toolkit that outline 10 elements of using TeachBack effectively. And it talks about what TeachBack is and reinforces those 3 points that we made before. The toolkit has videos to kind of give you insight from a manager who has done a lot of coaching of their staff in a clinic, a nurse and a physician and others to use TeachBack. And then there are the additional tools that I'll show you in just a second. Well, I'll mention that in a minute. So there's, based on the behavior change literature, Prochaska and DiClemente and Rolnick, it's a good idea to assess how convinced people are that TeachBack is important, because if they don't think it's important, you want to talk about it in a different way. If they think it's important, then you look at their confidence and whether they feel like they're confident in using these various elements of TeachBack. And this can be completed before you would maybe start some work, a month after you've done an intervention, and then 3 months later to see if it's been sustained. So this confidence and conviction scale are helpful tools. There's an observation tool that parallels those 10 elements so that you can use that to see where people might fall in terms of using those different components. Yes, no, or it may not apply in that setting, and make some comments that you can then use for coaching. There are coaching tips to help people make changes in their behavior and their practices without feeling like they're being forced or critiqued to make those improvements. And there are some examples of how you can build teach back into your care processes, standards of care, clinical competencies, order sets, etc. Again, to make it an always event. So I want to do another breakout. And George, I don't know if you can copy those two documents into the chat. I've got actually just the one right now. I've pulled all those tools together into one PDF document, and there it is. If you didn't get to download it earlier, but maybe you've already got it, we're going to give you about 8 minutes to look at those, kind of pick one or two that you think would be helpful in your setting and discuss how you would use it. And then when you come back, we'll have you share that in the chat. So want to go ahead and reopen those breakout rooms? Okay, well, according to my screen, everyone's back in the main room. Would some folks be willing to type in the chat which tool they might have chosen and how they thought it could be helpful? Okay, group 4 had a great conversation about how the insurance companies could use TeachBack to make sure patients understand their benefits. I will second that personally as well as professionally. Another comment from group 4, their organization is actively using the website and all the tools. I assume the website means the TeachBack Toolkit. That's great. Do you want to share any more about how you're using them? Are you using them on different units? Are you in a clinic setting or a hospital setting or a?
I'm in a large healthcare system in Delaware, the largest in Delaware, but Delaware is a small state, and we're just doing a whole system-wide initiative, like from hospital all the way to outpatient to home health to everything. And so your toolkit has really, the IHA's toolkit has really guided all the training materials that I build myself in-house. Because we did get permission to use some of the stuff, you know, and I know it gives permission to use the stuff, but we've tweaked a couple things just to make it a little easier for all the workforce to use it. So just very excited about all the work we're doing and hope to share it with others sometime too. But thank you for the groundbreaking work that you did with all of this, because I know you're one of the originals, Marianne.
Well, thank you. I appreciate that. And I appreciate, that you're finding it useful in a whole variety of areas, as opposed to just one particular area, and helping point out, which I should have and should do, that this is all usable in the public domain. We appreciate when people ask permission to use it, and we very much appreciate the citation in your work. And the interactive learning module can be used in your organization. We do ask that people not break it apart because it was put together as to be a whole. So here's a couple other comments on open-ended questions, prioritizing topics, finding that the observation tool is helpful. I think I've seen people use the observation tool like with one person kind of observing people. There was a clinic area I visited a while back where they actually had physicians observing each other, and they put it on the door. and they just picked it up and went in and observed their peers. So there's a lot of ways to use these tools, especially if you lay the groundwork so that people appreciate that it's about making improvement and not being critical. So thank you for the feedback. Please keep entering it, and we're going to move on to wrap up our session in the next 20 minutes. So what are your next steps to increase teach back in your setting? So we all have our traditional methods, which is, grand rounds and lunch and learns and then conferences, et cetera. But a couple other tips. Make it personal. Pull stories out of your participants or add them from your own perspective to make sure people realize that these things happen in your setting and their setting, and share those stories because they're very powerful. And make sure that you close with some kind of a call to action. What can you do by Tuesday? It doesn't have to be planning to plan to plan. It can be, could you try using a plain language handout for one patient? Would you be willing to try using teach back with the last patient tomorrow so you don't have to worry about being caught in a long conversation? Could you involve a patient or a family member to get feedback to help you improve a process that you're working on? Another idea is to use marketing strategies, which is sort of similar, but you want to think about the thought process that goes behind selling things, right? So it's not just off the cuff. People who are experts in this, they plan it, they explain the benefits, and they ask questions to elicit engagement by the people or person they're talking to. How do you feel when patients don't keep their appointment or follow their medication regime? Where do you see yourself using teach back? Where would it be most helpful? How do you see yourself using this reader-friendly guide? And don't be upset by objections. It means people are interested enough to actually listen and think about it. You can restate those, clarify them, address their concerns and validate them, but then support your point. And again, close with a call to action. Would you be willing to use this? Would you be willing to try? And follow up. Can I circle back with you next week to see how it went, or email you to check in? Another, the concepts of coaching, there's a whole body of literature on coaching, but think about it up front. You want to motivate the people you're working with, the people you're coaching, honor their tremendous current work, recognize that change is hard and it's natural to resist change. Your goal is to foster this new skill development and to build that into a new habit, to build that into their current work patterns. And then provide ways to do it reliably whenever it's indicated with standardized work, reminders, defaults, prompts, and recognize that it's never going to be 100%. If you get busy, you forget. So you do follow-up coaching, you problem solve together, and you recognize and reward your champions. And again, thinking about when people do have concerns and are ambivalent, explore that. That's interesting. Tell me more. Why do you say that? What makes you say that or ask that? And then direct your comments to what their concern is. If they don't understand, you want to explain and educate. If there's a different perspective, you acknowledge that and then address the importance. If they have other busy things going on, validate that. They do. And try to problem solve together. And if there are barriers, think about what are those specific things and how can you come up with a plan to address that. Remember the power of one. PDSAs, plan, do, study, act cycles. That's the essence of improvement work, quality improvement. So maybe it's going to be one early adopter, one champion, or would you try this with one patient or in one location? And please don't get focused on major long-term plans. Be willing to try and test things. Drop down a couple levels to plan these small tests of change. That way, if they don't work well, you can fix it and try it again, as opposed to having the whole thing go awry. So what might a plan, do, study, act cycle look like? Dr. S wants to try teach back with their last patient. She thinks it's going to take a lot of time and it's going to be uncomfortable, but she did it. She tried it with the parent of her last patients. a mother who was a teacher, her child has seizures. Turns out the mother mixed up her change in medications. So Dr. S re-explained and asked for teach back, and the parent correctly explained that. So this was the planning and this was the doing, but the important part is the studying. What did Dr. S take away? Well, first, she was surprised that a teacher mixed up this change because she thought it was so straightforward. A teacher would understand. She was glad she found out about it and was able to re-explain it. And she felt okay about asking the parent to explain it, and that it didn't take as much extra time as she thought. And she noticed that the parent appeared relieved because she now really understood what to do. So now Dr. S is going to try it for a couple days. She's going to try it with 5 more patients. People who have other conditions. She's going to keep track of her time, how she feels and how she perceives the patient feels about it, and how many times it takes to teach back the key information. That could help her tailor how she explains things. And then you can ramp up, you can do multiple PDSA cycles over time. So you build confidence, you spread it, maybe more conditions, more days, or more providers or settings. And Carla says the teach back observation tool could be helpful training our clinical as well as administrative staff who deal with members of the mental health community. With high turnover, this could be used when training new staff. Thank you for saying that. This will help new staff get up and running more quickly. I wanted to catch that there as I come back to how some work was done several years back at Children's in Columbus, where they focused on using teach back and inpatient units and did a variety of training and actually increased the number of discharges where teach back was used over time. So that's how you can use quality project to focus on use of teach back. You can also build teach back into other quality initiatives. Look at all the other drivers and opportunities, all this work that we all have going on, reducing unplanned readmissions, chronic disease management, improving patient experience. We have our friends who do accreditation and regulatory authorities, whether it's Joint Commission or CMS. Graduate medical education includes interpersonal and communication skills as a key competency. We're working in equity, quality and safety, and also it resonates in risk management. And Carla, why I said that, in terms of sustaining improvement, how do you keep it going? You may train everybody, but then what? So you have position descriptions, you build it into those, and performance reviews. Find out how you can build it into orientation and credentialing, perhaps. So when somebody changes a role or they come on board, they learn about it as an important part of how your organization does business. Obviously, training education, look for order sets, building it into care processes and competencies, build it in throughout the encounter or throughout the admission, so you don't wait for all this stuff to happen just at discharge. And use your EMR. You can use it to prompt use of teach back. Whether the patient or family was able to teach back the plan or the goals, yes, no, partially. And you can include not asked to do so, because sometimes, frankly, you're just too busy or it doesn't work right. And this helps by having that as an option. You avoid people just checking yes, because you're legitimizing the fact that you may not always do that. And you can get those data and then feed that back to people, your providers or your other staff. Get teach back and health literacy into your quality meetings and measures on your performance scorecards. Consider looking at communication related adverse events where use of teach back may have been helpful. Involve lay readers in your materials development. Make sure if you're in an academic setting or not, faculty should teach and role model use of teach back and evaluate their learners for their use of it. You want to recognize the champions and those who are using it and doing it well, and teach patients and families how to elicit teach back, because they may want to do it, but not all of us aren't doing it yet. So you say, wait a minute, doc, I want to make sure I got this right. This is what I heard you say, to get that teach back to come toward them. Clearly focus on higher risk situations and make sure everybody on the healthcare teams knows how to access a trained health interpreter, can pass along the need for clear communication, can stop the line if they feel that a patient or a family member doesn't understand, that they use teach-back appropriately. And wouldn't it be cool if everybody always said, well, what are the health literacy implications of this, whatever this might be? We're going to hang up a new sign. We're going to start a new initiative. We're going to start a new this or that. It should be part of inherent to our work. Okay, so we're going to wind up here. I want to give you a minute to pull up that other file in the document. Maybe George, you could copy that if people don't already have it, the planning document. Think about your goals and what you want to accomplish when you return home. What step or steps do you want to take and how you're going to share your plan. And then George, can you also put in that menti.com link and the code? When you've thought about that, I want you to go to menti.com, enter that code, and I'm going to switch over while you're thinking and doing that so we can see what everyone thinks. After you have thought about that, and after you've entered your thoughts, go ahead and minimize your screen, and hopefully we will start to populate what people are thinking about this. And George, can you confirm that you can see my screen, the Mentimeter screen?
Yes.
Okay.
And yeah, quick heads up, we're about 10, 11 minutes out.
Okay. Is anybody having problems, or are you all thinking deeply and typing? Here we go. Okay. And if you want to enter 2 or 3 more short things, that's fine. I want to start practicing teach back in my work and daily life, so it becomes a habit. I have also found that I use teach back in my personal life as well. When the kids were little, we would say, I want to make sure I understand which one of us is picking up the kids tonight. Finish the teach back curriculum I'm developing at Christian Care, and I will share the plan with my team. I think my chat might be covering up a couple of these boxes. Add more teach back tips and research in the courses that they're teaching. Getting leadership buy-in. Use preceptors for observation, for teach back observation for the nurse residents. Share the toolkit. Develop training for staff. A whole array of staff, those who have direct interaction. Build the case for teach back. Thread the concepts into the MPH curriculum more explicitly. Daily life, good. Begin teaching nursing students. Okay, great. Give it just another minute. All the resources that we use. And engaging providers as champions. Yeah, if you can find even 1 or 2 champions, that's okay. We sometimes spend a lot of energy on the resistors, but build capacity and build those champions that you have and that you can find, and then build it into new training. Great. Okay. All right, I'm going to go ahead and pull up the last bit of our presentation together. Again, George, you want to confirm that we're back on?
You're good.
Okay, thank you. All right, one more poll, everybody. Again, on a scale of 1 to 5, now that we've had this workshop and discussion and some tools, how confident are you that you can use it to advance use of TeachBack in your setting? Okay. Give it just another second. And I feel like we've shifted our curve. If it was it's not really a curve. If it was a vertical bar chart, it's a horizontal bar chart. Closer to good and very good. I think it was a little bit more, I think good was our highest result last time, but we are seeing more of a shift to the more confident end. And I hope that that is indeed true and that this was successful in helping you achieve that. So that pretty much wraps up the workshop. Remember, at the end of the day, it's for the patients we care for and their families, or the patients and people who live in our communities. Some of the resources that we've talked about today are here on the resource slide and included in your PDF of your PowerPoint on the IHA conference website. A lot of great people contributed to putting the toolkit together. And for those who asked about the URL, there's the URL and my contact information if anyone wants to reach out. And I appreciate the comments in the chat. And I think we have time for a few more questions. I'm going to flip back to that preceding slide in case people want that information. So we've got about 5 or 6 minutes. Any additional questions? I appreciate the comments. And I would invite, if anybody wants to, not just chat in a question, if anybody wants to unmute, go ahead and share a thought or a comment. Do you have any tools or resources to teach patients how to elicit teachback? Great question. I'm trying to remember if I don't know that we have any videos, but we did do some work with that, again, with the adult learners and the New Readers of Iowa to help them feel confident in eliciting teachback. And I think you could even make your own video, but think about it for yourself. What would you do if I remember myself, I had a really good doctor, great doctor, smart doctor, talked way too fast and it was complicated. And I finally just said, wait a minute. And I think I might have even put my hand on their arm. So I think and that would take a lot of confidence to do that, I recognize. But I do think it's easy for people to say, I want to make sure I heard you right. I want to make sure I do the right thing. I want to make sure I understand what you said. And then just to go ahead and restate it. And I think the physician will have to stop, or the nurse or whoever, and say, no, let me make that more clear. Or no, they may even say that's not what I said. But at the end of the day, the person will come away with a clearer understanding. So I think part of it is communicating that it's okay. And part of it is kind of giving a couple examples like that. We also found Ask Me 3 to be a useful tool for that. Because if you're probably familiar with Ask Me 3 questions that everybody should end the encounter with. What's my main problem? What do I have to do? And why is that important? And if you have everybody coming away saying, did you get your questions answered? We want to make sure you know the answers to these questions before you leave. That's another way to help people realize that questions are expected and encouraged, and we want you to have the answer. Yeah, Christine, it's close, but not the same. But it was a parallel, I think, in terms of sort of that patient empowerment. That's how we used it in Iowa. Great question and very thought-provoking. Thank you. And if anybody has other ideas, please add them to the discussion. Yeah, and making sure they know that the care team expects it can help. And that's why we frame it, right? What questions do you have, as opposed to do you have any questions? So that it's like, well, of course you have questions. What are those questions? That's a subtle thing, but if used consistently, that can help influence that. And that's what fits in with the whole concept of the care environment. It's not just a beautiful lobby, it's a setting that says, we want you to feel comfortable asking questions. The way we operate in our organization is we expect questions, we encourage questions, and we want to make sure that you feel comfortable asking those questions. Thank you, Carla, you're welcome. Any other thoughts? We've got a minute or two left. Well, 1 minute. I'll just wait. And if people want to ask another question, that'd be great. I think my contact information is also on the conference website. Good luck to all of you in your work. Thank you for coming. It was great to work with you, and it would have been wonderful to be in person, but this was hopefully a good alternative. And IHA has done a great job with this conference. Oh, let me thank George and Mario and Emma, who all helped this run well, because I may talk about teach back, but I'm technologically, this was complex for me. I did a lot of teach back to make sure I knew what I was doing. And you're welcome, everyone.